Environmental Services,
Sorry about that,
Public,
Lord. Go ahead.
that's all right, Public Health, Board of Regents, and Department of Social Services. And so in 2014, they came together, consolidated, and formed the Office of Early Childhood. However, it was in May of 2014 that it officially became established as the Office of Early Childhood. Next slide, please. Thank you. And so with that again, OEC is responsible for children in Connecticut from birth into grade school, and that's over 182,000 children. But it's important to know that it's not just about us overseeing and telling others what to do. We recognize the importance of a partnership and collaboration. Therefore, partnering with families is very essential in supporting the children in Connecticut and beyond and abroad, and also supporting the providers, teachers, and professionals. Collectively, we know that this is what is important in helping to support and raise children. And I often make reference to the African proverb, it takes a village to raise a child. And this certainly is one example of that. Next slide, please. In doing so, I want to always be reminded of the mission and vision statement, leading and guiding the steps of the Office of Early Childhood. But before doing that, so thankful for the leadership that we have in the state that supports these principles and values. We're so thankful that our governor supports the importance of the mission of recognizing all children and families and doing so through a lens of equity. And for that reason, I do want to read our mission statement and the one that our commissioner very much supports as well, as it reads, to partner with families of young children to advance equitable early childhood policies, funding and programs, support early learning and development, and strengthen the critical role of all families, providers, educators, and communities throughout the child's life. We will assertively remove barriers and build upon the strengths of historically disenfranchised people and communities to ensure fair access to OEC resources. And again, this is our mission, and we have a vision that supports moving forward in that regard as well. Next slide, please. So in terms of how we conceptualize behavioral health within OEC, we recognize that behavioral health represents mental health, spiritual health, and physical health. Now, before anyone gets concerned is thinking, oh, spiritual health, and we must separate church and state when it comes to state policies, we're not talking about religion per se. We're talking about recognizing there is something greater than you, a purpose bigger than you that motivates you and strives you to move forward. We certainly know when it comes to mental health, that relates to our emotional and social and psychological well-being. And our physical health is very much connected to that as well, in terms of being impacted by how we are doing in terms of our mental health and spiritual health. So collectively, this represents behavioral health. Next slide, please. And so with that, we strive to operate through a lens of prevention with the different initiatives that are supported by OEC and our state partners, our state sister agencies as well. The different pieces you see listed there are the different initiatives within OEC that we support to uplift behavioral health. But again, want to emphasize we do not do this alone. Many of our state partners, sister agencies, that is, also support many of these principles or these initiatives. And as we know, when it comes to primary prevention, that is where you are implementing a prevention for all. All persons are exposed to that. Whereas secondary prevention recognizes those that may be at risk and wanting to provide the preventative services to those that may be at risk of a challenge. And tertiary recognizes, nope, there is a challenge, there is a problem. We want to implement this service, try to return them back to baseline. So we view the different initiatives that we have through that lens, primary prevention, secondary, and tertiary. And with that, I'm going to highlight two specific ones that are going to be talked about further with our colleague. One is mind over mood. Oh, not yet. Pardon me, one slide back, please. Sorry. Mind over mood and also doula work. And mind over mood we view as a secondary and tertiary level of prevention. And our doula work is a primary and secondary. But want to be able to have you to have more information about these efforts. And so with that, we'll pass it off to my teammate, Ashley McAuliffe. Ashley?
Thank you, Lorna. So I'm going to talk a little bit about the Mind Over Mood initiative. This is an initiative that is embedded within the programming of the Connecticut home visiting system, and it's really there to address the barriers to treatment and care and to mitigate risks and incidents of adverse maternal and infant health and mental health outcomes. There are 6 initiative components to Mind Over Mood, and those are maternal mental health screening and referral protocol for the home visiting system, training technical assistance and consultation to the home visiting system and the sites, psychotherapy referral coordination programming, outreach training and partnership with specialized independent psychotherapists, specialized clinical service for partially and uninsured mothers, and collaboration with statewide perinatal mental health stakeholders. Each of these initiatives components address critical needs, perinatal families' mental health, clinical services specialization, capacity and access and systematic identification and linkage to clinical services. And our Mind Over Mood is really the catalyst for support, treatment, and care for perinatal families enrolled in our early childhood home visiting system. Addressing these unmet clinical needs of perinatal and early childhood mothers is really at the heart of the initiative for Mind Over Mood. Next slide, please. So here you can see there are a lot of different resources, and these are all housed in what they call their Padlet site. And there is a link on this slide. So when you get the slides, you'll be more than able to access all of these resources and share them out or utilize them as you see fit. Next slide, please. And then we have our program over at the York Correctional Facility for Women. So this correctional facility houses roughly 850 inmates currently, but it can house up to 1,100 of them. This program really looks to support women as they come into the facility that are either currently pregnant or postpartum within the first year of their child's life. It manages the pretrial and sentenced offenders in this unit, and they can be anywhere from 18 to 25 years old. Our current program in the past year a little bit more than a year, between July 1 of 2023 and June 30th of 2024, we provided services to 97 different women. There were 15 births during that time, and 100% of those moms breastfed at birth, with 85% of them continuing on to pump when they returned to the facility. In 2023, there was a need to increase our services from 1 and 2 doulas to 4 doulas that are providing the support to the women. And in 2024, we implemented a pilot where we provided home visiting services within the facility to the pregnant and postpartum moms. And then some of those moms were released into a halfway house, and we continue to provide support there. Additionally, we provide resource connections with our home visiting services for the families that are taking the children once they're born. And then one more slide. This is just one example of something that we do with our moms every year. So each mom was able to decorate the different flower petals with things that they wanted to say, or parenting words, or words of encouragement. They were encouraged to use both a positive and a challenging aspect of their parenting. And then these are posted within their tier. So we really work to connect the moms and the babies together as much as we can through different activities that we then share with the rest of the women in their unit.
Thank you, Ash. That was a great overview from Connecticut's landscape. Now we are going to look into what's the work that's happening in Rhode Island. So we have Sara and Jim from the Rhode Island Department of Health speaking about Mom's PRN program. As you introduce yourself, I can pull up the slide from my end.
No, thank you so much, Ash. And again, my name is Jim Beasley. It's a pleasure to present along with my colleague, Sara Remington. We both work for the Rhode Island Department of Health. I work more in the maternal child health unit with some specialty with the Mom's PRN program, which some of you may be more familiar with. The pediatric version of it in the state of Rhode Island is called PDPRN, which Bradley Hospital has been the wonderful clinical lead. And certainly there's similar sort of these access programs in Connecticut and Massachusetts and New England. I believe in Connecticut, it's called Access Hub Team, and the McPAP model up in Massachusetts. So certainly looking forward to contextualizing some similar supports that we've been able to provide to the family visiting critical workforce to help them with their actions with addressing maternal mental health. So if we can just go to the first slide, and it's just giving an overview of at the Department of Health, we're similar like in Connecticut, where, oh, sorry, next slide, Ash, thanks. We're the sole public health authority for the state of Rhode Island. That we don't have county level public health agencies because we're like a city state, we're small but proud, and we have a very similar mission to what Connecticut seeks to do, which is improve the health and safety of Rhode Islanders. But we define health similarly like Connecticut about the social and environmental determinants of health, really focusing on disparities in equity and, of course, high quality care. Next slide. It's a critical issue, just like we're seeing across the country and in New England, maternal mental health. Our latest PRAMS data, which we analyzed between 2020 and 2022, showed that 1 in 4 pregnant and postpartum individuals self-reported experience mental health concerns or challenges during their pregnancy or postpartum period up to 12 months. And we continue to see a lack of access to needed supports. So even though our PRAM survey has been further refined, we're able to better assess access to self-reported access to care in the postpartum period. This survey that was fielded during this time period only asked about pregnant women, and unfortunately, 45% who did self-indicate that they were experiencing depression concerns or conditions or symptoms, they reported not receiving any counseling, and similarly, 60% pregnant women who said they were experiencing depression didn't take any medication. And just like so many other states, we are fortunate to have what we call our pregnancy postpartum death review committee. In other states, they're called the maternal mortality review committees. And so when you're looking at the absolute worst outcomes that can happen to a pregnant individual, we're thankful that we have very low numbers in the state of Rhode Island. But when you look at like who had the worst outcome possible of dying during the perinatal period, 50% of all those cases were related, if not attributed, that could have been prevented to behavioral health conditions. So this is ringing the alarm for the state. And so there's a multitude of initiatives that we're seeking to better address, most focused on supporting our statewide workforce, because when you look at the number of specialized behavioral health providers in our state, there's just not enough of them, especially when you're looking at the psychiatry workforce. We were able to do landscape analysis with the PD-PRN program through Bradley Hospital and looking at how many perinatal and pediatric psychiatrists that are actually in an outpatient setting in the state. And out of all the psychiatrists, only 11% serve the perinatal and or pediatric population. It's just not enough to meet the need. So if you go to the next slide, you can see sort of what the state is seeking to do to address this workforce shortage. And so there are 3 different statewide initiatives. We'll go into more depth about the Moms PRN program, which again is very similar to PD-PRN. It's a psychiatry access program. It's partnered with our wonderful clinicians at the Center for Women's Behavioral Health at Women Infants Hospital, which is the largest birthing hospital in our state. And that provides teleconsultation, but also professional education support, not just to clinicians, but also very trusted and critical community workforces such as family visiting. We've also been very fortunate to team up with Women Infants Hospital, who's also in the very beginning stages of bringing the collaborative care model to OB practices in the state of Rhode Island, thanks to federal funding. And that's just a fancy term for basically how do we get a integrated sort of nurse case manager that can more proactively help coordinate the timely screening of patients, but then also facilitating case management conversations between a perinatal psychiatrist at Women Infants Hospital with the OB at one of these 6 practices across the state. And like so many other states across the nation, we were fortunate to be in a 3rd round of funding a tranche funding stream that will last a decade for certified community behavioral health clinics. They're finally operational in our state of Rhode Island. We have 6. They have mobile crisis um, abilities. They're 24/7, and they can see patients in an outpatient setting regardless of their insurance, immigration status, or whatnot. There's further work, I think, to better optimize that model to meet the perinatal population, but it's something now that they're operational. We've been very happy to see that be in our state as a whole. So if you go to the next slide. And there's also emergent workforce supports that the department and other entities in our state are trying to do. One is trying to further support community-based health professionals, which are so trusted, like doulas, community health workers, peer recovery specialists, but also our addiction counselors with getting a certificate of competency in perinatal mental health. Typically, these workforces aren't licensed by the Department of Health, but they rather get their training through the certification board. And so it's in the final stages of finally having a certificate of competency. And we're working with a variety of entities about how best to roll that out and facilitate that training, which is, again, we're going to create an ecosystem of a no wrong door approach to connecting those impacted by maternal health to care. And we were one of the last states to finally establish a postpartum support international state chapter. So again, like that's just another work group where they're trying to increase awareness, not just amongst the perinatal population, but also as a professional entity to connect people to care. So if you go to the next slide. And so what we wanted to really highlight as our successful model that should be replicated or make everyone aware of is how the Mom to Parent program really brought in its purview of support beyond the clinical setting to more of a community-based setting. And so, this is a evidence-based model that's been around for a while. In Rhode Island, we've been operationalized for 6 years. And it's Mom's PRN, just like PRN. It's a statewide clinical teleconsultation service, which basically provides and helps streamlines the resource referral avenues for anyone seeking access to care. But if you're also a clinician, you can talk to a perinatal psychiatrist and get that real-time diagnosis, medication, and triaging of your clinical needs of the patient more immediately. And so we've been having wonderful success with this model where we've had over 3,000 calls impacting 2,600 perinatal people across the state. But the key driver, if you go to the next slide, has been this partnership with the home visiting program. Like almost a third of all of the calls to the teleconsultation lines come from our community-based professionals like doulas and mostly family visitors. And so certainly wanted to provide this case example of like how this works, specifically where, a family visitor, and Sara can speak more to sort of the wonderful additional training supports that they do, but in a real life case example is they often encounter a first-time mom who may be struggling. They implement a PHQ-9 screening, and then they have a positive result. And from there, instead of having to triage that themselves, they're able to basically connect with a mom's PRN resource and referral specialist that has this wonderful vetted directory of like 400 different service providers across the state and really provide that like localized and personalized care connection pathways that factors in sort of geographic, linguistic, health insurance, but also most importantly, the actual clinical concern that's happening. And so what you often see as at the bottom of that thing is the result is that you just have a more timely access to resources for the family visiting client. And they're not alone in doing the critical work because we know that oftentimes, especially postpartum, the mothers will certainly, oftentimes prioritize the clinical care of their kiddos, and so they may not make it back to their OB. And so having these discussions and screening pathways in a family setting through like family home visiting services, which is comprehensive, I think provides a lifeline of support for these folks. So if you go to the next slide. and can certainly let Sarah speak more to sort of the holistic impacts that the Moms PRN program has been able to support with the family visiting program.
Yeah, so we're really fortunate that Rhode Island was able to participate, pretty soon after the Moms PRN line was launched. It's been a lifeline for the family visitors. They're in their homes, working with families with high needs, and to be able to call right then and there to try to connect a family to services proved invaluable. So it's one of the best initiatives that our family visitors will tell you that they partake in. And so you can see, a lot of the calls are coming from the family visitors themselves right there while they're in their home. So they're able to say, here's where we're going to refer you to. Here's the name and number of the person that we're going to call right now, and do so with the family's permission so that there's buy-in for that service right then and there. So the Moms PRN program has been an amazing resource for our family visitors. Next slide. One of the things that the family visiting program did is we're primarily funded through HRSA and the Maternal, Infant, and Early Childhood program. But we also have a state homegrown program called First Connections. But our evidence-based programs participated in a large national CQI initiative, which they call a COIN, on maternal depression about a year before COVID. And it was to improve our screening rates. We recognized that our screening rates using the PHQ-9 had to improve. And so with this COIN that we did, the CQI initiative that we did, they were able to improve their screening rates. And then not only just their screening rates, but their referrals to care for parents and caregivers that did have an elevated PHQ-9. And then also symptom reduction. So you can see the results here from that national CQI initiative, but we've actually been able to sustain the gains, even though we're a few years out from that. So right now our screening rates are at 94% for our last performance report for the PHQ-9. Referrals kind of dip here and there. It's still a work in progress, but again, the main place that folks are accessing first when they recognize that a parent or caregiver has depression is the Moms PRN line, because that's a trusted resource and it's so critical for family visitors to have that tool right there in their toolbox. Next slide. So Jim and his team are wonderful. We have the Moms PRN folks come out. They're part of new hire orientation for our new family visitors, so that family visitors know right away that this is a valuable resource for them. Not only the Moms PRN line, but the PD PRN line as well. We have increased our training on how to document all the good work that the family visitors are doing, and to give themselves credit for what they're trying to do with parents and caregivers regarding the documentation of referrals, and then really how to engage families in care. We know that not every family is ready to receive formal services. So we have some staff that are trained in a curriculum called Mothers and Babies. That's out of Northwestern University. And we continue to look for other paths or other training opportunities to support the family visiting workforce for those families that can't or do not want to access formal care. We know that there's still a stigma attached to accessing behavioral health supports for many families, so we never want to let our family visitors leave a home feeling like they can't do something with the family and offer them some kind of support.
What's also been so interesting with this collaboration with the family visiting program and the success that we've seen when you're providing the just-in-time training, whether it be facilitated by national partners or also local supports or evidence-based models, is because it's been such a successful initiative and key strategy to sustained utilization of the Moms PRN program and a lifeline for impacted caregivers to receive needed and timely treatment. We've been able to replicate this approach with our WIC program in the Rhode Island Department of Health, and are making more efforts to further engage the early childhood professionals as well. Even the PDPRN program has recently pivoted. They were solely just focused on clinical care, pediatricians, and with their continuation federal funding, have really pivoted and replicated what Moms PRN has been doing, and also trying to better support the early childhood professionals in our state. So we're seeing, a nimble adoption of what was a clinical support to more of a community-based support to really create that no wrong door approach and to streamline what can be a very complex and challenging process, which is like who is accepting, where can we get outpatient services, who's taking the insurance, like all of that care coordination work can be leveraged and streamlined more appropriately across the state, not just for clinical providers, but oftentimes the community-based professionals who are more trusted and may have more likelihood of getting that disclosure compared to a very formalized clinical setting.
Mhm. Thank you, Jim. With that, I'll stop sharing the screen and we can have more candid chat over here. As you spoke about high-level challenges from Rhode Island's perspective, Lorna and Ash, could you also share your perspective on what are some common challenges that you see from Connecticut's landscape, and what's the way around with those challenges? What do you think is the next steps as well? Could you high-level touch base on it?
Certainly. I'll start with the high level and then pass the baton. I think our high level is one that certainly I think all of states can reflect and account for, and that is in terms of sustainable and predictable funding. I think that unfortunately can hinder how to operationalize next steps if you're wondering what funding may be available and how to allocate said funding. But even putting that piece aside, I think also too it can be a challenge. And thank you. It was so good to hear Jim and Sarah make reference to this as well in terms of the stigma of receiving formal services and formal mental health services. So that is something that is a bit more intricate to address because that is reflecting people's mentality, how people perceive and respond to this topic. So if we want people to address and embrace the importance of maternal mental health, it's important for them to believe in it and recognize that it needs to be addressed and supported. But then that has me to approach it from a two-pronged approach. Some may believe it based on the information that has been shared thus far today and focus on the social and emotional development of a child and the mother and the generational health that we're trying to support. But then we must also recognize there are others that only respond to the quantitative information, the data, the numbers. How is this going to be funded? How is this investment going to pay off dividends moving forward? And for that reason, that's where data is so very important. Data, statistics in terms of why this works can help support all the more the pieces that we're talking about. But Ashley, please do share more in more granular details with respect to Mind Over Mood and doulas.
Sure. So our Mind Over Mood and our doula work is all funded through the Community-Based Child Abuse Prevention Grant through ACF. And so, in the past 5 years that I've been in my position, the grant has been steady, and we've been able to leverage additional funds through our fiscal department, which has increased our award and allowed us to expand these programs. There's always the risk that, the federal government could say that you're only going to get your baseline amount for Connecticut. And if that were the case, then we really would have to reevaluate and figure out exactly how we could potentially fund these programs moving forward. We haven't had any issue as of late, and fingers crossed we will continue to not have any issues funding these programs. We're always looking to really try to build as much as we can into our Connecticut home visiting system so that there's always access to these programs through a pathway through OEC. But at the moment, we've been very lucky in terms of our funding and our sustainability. So these programs have only grown as opposed to being pulled back and having to kind of cut down over time.
And with that, if I may dovetail into next steps, thank you so much, Ashley. I think although we may have some areas where funding is more sustainable, again, looking at the bigger picture of other initiatives where that funding may not be available and sustainable. And so for that reason, we know that we are not in this alone. We must partner and collaborate interstate within Connecticut, but also intrastate rather within Connecticut, but inter in terms of our other states, neighboring states. And again, so honored to be here with Rhode Island. And thank you, Ash, representing Massachusetts. Speaking more intrastate within Connecticut, we also recognize the important partnerships we have with our sister state agencies and also the community at large. I'm so honored. I see one of our teammates here, one of the screens here, Mr. Howard, who is affiliated with the Connecticut Children's Children's Medical Center. We know that that is an entity that we certainly must partner and collaborate with. And something we've realized over time as well is over the years, there have been many different groups that have formed to address behavioral health. A group has formed here, and then a group has formed here, and then a group has formed here. And folks are realizing, well, we have these different groups and we have the same purpose and goal. Well, let's see if we can work together smarter versus harder. And so there are now efforts to have these different state groups that are comprised of different forms and representation looking at behavioral health. Let's see how we can try to formulate and work together. So honored of one of those entities to be a part of the TCB, Transforming Children's Behavioral Health Planning and Policy Committee. This is one that is issued on a state level, comprised of state delegation, but also community partners and providers. And it's an important way of all of us coming together to recognize the importance of addressing behavioral health systemically. Again, not just working on one thread, but how we can create a wide web that impacts the children and families in Connecticut and abroad. And I say abroad intentionally because Rhode Island, you're not that far away, and neither are you, Massachusetts. So what happens here is going to impact you all and vice versa. Again, we must work together in this effort.
Thank you, Lorna, for setting that stage. Jim and Sara, any comments from Rhode Island's perspective?
Certainly, the funding sustainability piece is, something that we too are looking at with variable sort of outcomes, at least at the RIDOH family visiting side with the mom's PRN side, we were, at least with the mom's grant, we weren't awarded continued federal funding. That being said, because the program has demonstrated its success, we've been able to identify some patchwork funding streams and are hopeful about some state legislation that is modeled after Massachusetts through a health plan assessment fee, basically to sustain the program services going forward. But RIDOH has also been collaborating with other state agencies to incentivize additional sort of like regulatory pathways to get some funding. And one of them has been through our Office of the Health Insurance Commissioner, and certainly trying to leverage sort of mandates to, as Lorna was saying, systemically address behavioral health. There's been now behavioral health mandates put on our commercial health insurance payers to increase their spend on children's behavioral health, and they've defined it holistically, where it includes perinatal mental health as well. And so there are carrots and incentives and regulatory authorities to allow any contributions to meet those thresholds to support programs like Mom's PRN, but other evidence-based models. And so I can turn over to Sara about any funding insights about the family visiting program.
So we are largely funded through the Maternal, Infant, and Early Childhood Visiting Program, and knock on wood, our funding is remaining stable for the next couple of years. It's been reauthorized for 2 more years. I think our biggest challenge right now is just workforce. There's shortages in pediatric care and primary care, but also in the family visiting world. It's hard to retain family visitors. So we are lucky enough to still dedicate some funding to some of our partners on this call through Bradley to provide some consultation and support to our LIAs or agencies, because the work is hard and it's gotten a lot harder in the last few months. So we want to make sure that we're supporting our workforce so that we can better support families.
And what's also been interesting too is like the state proactively through our General Assembly, but also other lead healthcare agencies are really proactively implementing rate review studies. And there's certainly a lot of growing political will to ensure that those rate review studies, not just for the clinical world, but also the entities that address the social determinants of health or social service entities, that those rate review recommendations are funded. Easier said than done, but it's another pathway that in Rhode Island that they're trying to support and be holistic with trying to steady these workforces.
Thank you, Jim. I know there was a rate study done in Connecticut as well last year, which again showed what those rates look like versus, and they did an analysis with other states as well. So continued rate study is required to better support the workforce and to sustain the workforce as well. Of lately, I did see a lot of increase in bilingual population across Rhode Island as well. I'm not sure what that stats look like in Connecticut. So it's having a workforce which can cater to that population is also required. Um, uh, Lorna, could you speak about how that's kind of addressed in Connecticut's landscape?
Certainly, it is one that is needed and one that is recognized that is of need. And again, with us operating through a lens of equity, we must practice what we preach in that regard.
Mm.
And with that, in terms of increasing our workforce and bilingual staff, but also recognizing trilingual and multilingual, because I think many times we think of just bilingual just in terms of English and Spanish, but we have
Mm.
many communities that have a wealth of different languages spoken in their community. I know of one community in particular that has over 70 languages spoken in that community. So that mindset of recognizing bilingual and how to define that. But unfortunately, it also again comes back to funding and sustainability because the workforce needs to be supported. And that is something that we continue to advocate for to increase and support the funding to support said workforce. And when you think about it, and with the lens of early childhood, with Ashley and I representing OEC, wouldn't we want to do that? At the earliest of age, our babies, our youngest of young, that's where we really want to invest in their growth and development. Therefore, we should be taking care of those that are taking care of them. And so that has been an ongoing conversation within Connecticut. And we are currently in a session, legislative session. So that certainly is a hot topic as well. But nonetheless, to your initial question in terms of multilingual staff, certainly of value, certainly something that we continue to press on with. And we need the financial supports to help in that regard.
Thank you. And I'll now open the floor for question and answer. So in case if any one of you have any questions, you can raise your hands, put them in the chat. Both are welcome. And as others do that, what is an ideal model for a maternal mental health program to look like in a state? What would a North Star would look like with a comprehensive model, with great workforce? I know it's being a little ambitious, but if given a chance, what would that ideal model look like where there's less barriers to services, more access, people are using it, there's more awareness in the community to make most use of these services that exist out there. So what would that North Star look like?
If I may say, I think it's recognizing the continuum of services, the continuum of care. We cannot operate in silos with how we support mothers, how we support children. So yes, investing in those early prenatal time period, but also postnatal time period. But we don't want to leave it just there, continuing to support the early years of development and then into adolescence and adulthood. Why? Because those adults are one day going to create families of their own and are going to feed into helping to educate and support and raise said children who again are going to grow up. So it's a complete cycle. We are talking about a cycle of growth and development. So I think recognizing that importance really has all hands on deck in this regard.
Howard, do you want to answer? Do you want to take the question? We can't hear you, Howard. Not yet, no.
Now?
Yes, we can hear you now.
Okay. So Connecticut Children's, it's interesting. The majority of our patients, our kids, are below the age of 1. And much of what we provide throughout the state and even in New York are, NICU services, neonatal services. And we do know that kids who are born prematurely with health conditions are of a higher risk of other health ailments and mental health issues going forward, as well as the moms and dads who these children were born to. And I'm wondering if you can speak to the special needs that you see in this population of moms, of families, and of kids, both in terms of addressing the higher risk of depression and other emotional issues related to having a child with a special need, as well as what we can do to do early intervention and early screening of these children who are coming in with a higher risk factor for emotional issues as they age. So I know it's an easy question.
I'll start. Again, thank you so much for the question, Howard, and thank you for reminding us of the importance of those early years, but also recognizing when there may be developmental challenges. So, to your piece in terms of screenings, in terms of screening tools, we know that in Connecticut we support a model, the Sparkler mobile app, which is a screening tool to address developmental milestones if children are meeting them or overcoming them. It's not an assessment tool, it's a screening tool. And with this mobile app, based on what pieces may be determined from the screening tool, may see if a referral is made to birth to 3. And so it allows for a direct connection of whatever results come from the screening tool to alert and support a referral for birth to 3 services. But the app also does provide family engagement tools and mechanisms and things of that regard. So that is just one means of providing a screening tool that is accessible to all children, all families in Connecticut, free of charge. But to your other point, Howard, in terms of the supports that may be needed for the family, in terms of how their reaction may be to what their child may be experiencing and different mental health challenges that they are experiencing. Another piece too that we recognize and support is CTAIM. CTAIM is Connecticut Association for Infant Mental Health. And this is a program that really helps to educate and inform providers and those that are working with children. Some may say, well, mental health of babies, how can you really assess that? What they really look at is, well, how are you self-aware of you? Are you self-aware of how you impact the growth and development of a child? As we know, children, in terms of their brain development, things are happening day by day, minute by minute, second by second. And the interactions that they have with the adults in their lives can help that in a positive way or not so positive way. And so with CTAIM, that helps to educate the community and providers more of the regard of how they themselves are helping to influence the growth and development of children. Howard, pardon me, I thought I had the 3 pieces of your question. I think I just got 2, just had 2. Okay. Did that answer 2 with that? Okay, all right. But teammates, please do share your thoughts as well.
And certainly in Rhode Island, there's a growing recognition about how best to center this need. I think the state was very fortunate in the fact that we had wonderful partial hospitalization programs within women and infants for moms, and the NICU is also at women and infants. So just there was always a pathway and connection and a braiding of services. I think what is being built out now is more of that long-term sustainment and identification of needs. And so the state, through the General Assembly, created a whole infant and early childhood mental health task force, and it has guiding principles about where there are opportunities and challenges and recommendations to better strengthen the early childhood system within the broader system. And similarly, as what Lorna was talking about, we too have also teamed up and partnered with the Rhode Island Association for Infant Mental Health. They certainly provide wonderful, I think, reflective supervision for family visiting and training supports. And then more recently, with this whole Rhode Island certification board about this perinatal mental health certification that's really for the doulas, the community health workers, the peer recovery specialists, we're trying to, with at the very beginning stages of looking at their credentialing as far as making it clear to all of the health professionals who may get any specialization about sort of attachment bonding and training, and that the Rhode Island Association for Infant Mental Health offers, as it also relates to meeting requirements of the perinatal mental health certificate too. So it's trying to do workforce pathways that bridge the competencies, but then it's also trying to build out those systems that better respond to and are supported. So Moms PRN similarly is certainly trying to better engage, but we've had some staffing issues and funding challenges with doing it properly, of taking that replication of family visiting supports for early intervention staff across the state, focus on maternal mental health, because they do such a great job with child attachment in children's early mental health services. So more work to be done. There's a lot to leverage in our state, but it's a growing recognition that I think we need to specifically address, those families who are challenged with, a NICU birth and, trying to further enact needed supports.
Mhm.
And just to add on to that, to what Jim said, we're very fortunate in Rhode Island. We are small, but we have close relationships with our Infant Mental Health Association. The family visiting program supports membership so that our family visitors can access RIAM services, but also with Bradley, we've been able to develop a framework for reflective practice and supervision and mental health consultation that's available to all of our family visiting agencies to partake in. So that way that our teams are getting support, whether it's with a child with special health care needs or a family that has concerns about their growth and development. Our family visitors are then able to get some consultation from their mental health consultant because, again, infant mental health is an emerging field and our family visitors get it and people on this call get it, but it's still hard to explain it sometimes to folks that are outside of early childhood and to help them understand the need. So we feel really fortunate. We have got really great partners to tap into. We have a parent caregiver advisory council. Just a quick little anecdote. We were asking them how they were doing during COVID. Everyone was in lockdown. They were home with their kids all the time. And when you ask a new parent how they're doing, they start telling you how their kids are. And there was one mom who was just pretty distraught, I would say was a word, because she was concerned about her child's growth. So when we asked her about how she was doing, she was talking about how her child was doing. And he had been born with some kind of birth defect, and she was afraid that he wasn't going to get the services. And so we were able to elevate that and wrap her around in supports, even in a virtual landscape. So because her mental health was being impacted by worrying about her child.
Thank you for sharing that, Sarah. And just as you mentioned about the wraparound work, currently, when we look into children's mental health or mental health in general, you cannot eliminate the social determinants of health factor, their housing needs, their nutrition need, even diaper needs, financial component to it. So how are these programs creating that linkage to those community based organization so that those organizations can then better help these families with all those needs?
So glad you made reference to that, to all of the pieces that play a role in a child growing up with well-rounded care. One piece that we are so thankful for and appreciate is our early Head Start on housing. That is an initiative in partnership with our Department of Housing, where recognizing that housing insecurity is real, not only in Connecticut, but nationally. And this is a program that allows vouchers to support families that are at risk of or are experiencing homelessness, providing housing for them in partnership with owners that are willing to collaborate and partner with Department of Housing. And so that's something that we must recognize is very prevalent. Also, food insecurity is also something we must recognize as well. And when we think about children and going into pre-K and K and beyond, the first meal of the day, I'm sure we all heard it growing up, breakfast is the most important meal of the day. It really is, because if you expect a child to go in the classroom and be attentive and learn, but they're hungry and their bellies are empty and they're growling, that's not going to help promote them to focus and pay attention. And then instead of them saying, I'm hungry, I didn't eat dinner or breakfast, they will act it out. As we know, behavior is language of the child. And if we have someone or program that is not viewing a child's actions or behaviors, wanting to see all of the pieces at play, and they're just labeled a bad child who has behavioral problems and concerns, now we are creating a pipeline that is not helpful or productive at all. So very much appreciate the question of all of the entities that play a role in a child's healthy growth and development. It's food, it's health, it's housing, it's all of that. It's also the wellness of those around them. Thank you so much, Sarah, for making the reference of the mother and how she was feeling. If a parent or caregiver is overwhelmed and stressed and having their own mental health challenges, that's going to impact how they engage with their children or those children that they're helping to raise and support. So it definitely is a well-rounded approach defined by many ways.
Thank you.
And similarly, in Rhode Island too, the implementation of Mom's PRN training or our Compass Plus initiative, which is again trying to enact collaborative care, is that they're being implemented also concurrently or in collaboration with piloting and helping sustain social determinants of health screening. at
Mm.
clinical practices across the state too. So like there is, a whole more comprehensive and family-centered approach clinically that's being triaged. And I think what we're trying to also do is amplify the wonderful work that family visitors do in supporting those other professional pathways through the Rhode Island Certification Board, but also programs like Mom's PRN, where you can call and find information about a wide variety of social service supports. It's not just mental health or behavioral health. They also have information regarding intimate partner violence, sort of childcare, food. And so we're again trying to create an ecosystem of no wrong door and trying to create those collaborative partnerships.
I'll add too that our family visiting agencies all get trained on how to access our state's largest and only diaper bank, Project Undercover. Nobody should walk out of a home without knowing how they're going to keep their child healthy. And also, we do a lot of focus on safe sleep too. So again, we have used funds to support pack and plays and the purchase of side sleepers so that we never leave a home if a family doesn't have a safe sleep environment. So try to reduce some of those barriers that cause stress to parents and caregivers. We know that not being able to afford food or not being able to provide, diapers or diapering supplies can just be an enormous stress on families, and we try to alleviate that as much as possible.
Thank you for sharing that. Howard, I see your hand raised again. Go ahead.
Yeah, just before I just wanted to ask, are we doing anything around tracking the long-term impact these programs are having on kids? Do we have data that can objectively support the work that you're doing? Sounds like a lot of this is anecdotal, and I'm just wondering, in this day and age, we often need to look to data to demonstrate the efficacy of the
I had
program.
a similar question. Hang on. I'm gonna leave. Sorry. Yeah, I had a similar question, which was, is there any effort made to link participation perinatal mental health programs with data on children's mental health further down the line?
Greatly appreciate the question and certainly agree with the question of having the data to help tell the story. And that is something that we are collectively striving to do. We have data, but it's a matter of how to define the data and how to have the data to be integrated. And so that is an area of growth that we have recognized, that it's important for us when we're collecting information, how we're using it, but also it's important of how we are interpreting it as well. You can't just do a blanket interpretation of data. It's important to come through and have a lens that can recognize all the pieces that play a role in that regard. So Ellen and Howard, if we may come back to you with that, because it's a work in progress, but we certainly recognize the need of data and the metrics that are used to interpret the data.
Mm-hmm.
Yeah, certainly. Similarly in Rhode Island, we have the infrastructure to do this type of analysis because we do have an ecosystem that sort of merges multiple state sources of information. But we're also looking at our all-payer claims database and have done some linkages with other maternal child health databases and supports like family visiting. And the process takes forever to get a finding. So we are finally getting prevalence data, treatment data, and now we're beginning to look at sort of what are those outcomes and differences through that. And certainly the PDPRN program has tried to also look at that utilization comparison of those who are enrolled and use that service. What are the differences in sort of prescription or access utilization? It just becomes, with the funding that we have, it's a whole separate scope of work in addition to program implementation. And it is a challenge for public health agencies to do both adequately. So there's a lot of potential to do it. We welcome your ideas of how best to fund it. And because it's not the central core of operationalizing these supports, it's been hard to get at it, but we have been making strides in Rhode Island to look at that exact question. But more work needs to be done because it's easier said than done. Because as Lorna knows, it's so nuanced. So,
Thank you. We are almost about time. Any final questions, thoughts? before we wind up for the day? If there's any workaround, yeah, Howard, I see you, and Lorna, I see
I
you.
was just going to say universal bravo to everybody. Thank you. It's really, really informative.
Thank you. And if there is any data that we can share already with the group, please send it across to me along with the slides. I can share it out with all the members who've joined it and signed up for this webinar, please. And thank you so much, Lorna and Ash from Connecticut and Jim and Sarah from Rhode Island to help us with this perspective. And it helps us to break those silos, understand what different approaches are being implemented in different states, and it becomes easier for us to drive it home to our own states then. So this was really helpful, and continued efforts still remain, and we plan to have more such engaging series with all of you. So stay tuned to all those who've signed up for our newsletters, our blogs, and our outreach. There'll be more webinar updates coming in from our end, and this will live up on our website. So if you want to go back and visit the conversation, you can always do that. Thank you. Thank you so much for all the questions, and thank you for all the work.